So we have more time to do other things. Then we are talking about gynecology. In gynecology, the main topics that you have to start from, you can read all of this one, the normal anatomy and all of this one. And then don't forget to read the sidebars. That's kind of important. You can read this one, the follicular phase, which hormone is high, and then secretory phase, which hormone is high. That's kind of question that is supposed to be asked. Like luteinizing hormone is high on the evolutionary phase, then FSH is high in the early follicular phase, at which phase they are equal. So just for your convenience, and even in some time they do ask the questions about this menstrual cycle, and they do ask about luteinizing hormone is high in which phase, like it's a direct anatomy question, and they do ask this question. If you don't understand this sidebar, you can just read this one: estrogen effects, progesterone and progesterone effects. Why? Because of the contraceptives, it will help you to understand what's going on. Then the stages of puberty is important because a scenario can be given where a female or a male is not having the stages, or did not reach to the stages. So what's going on in that stage? So CHA, congenital adrenal hyperplasia, could be there. That is the problem. And then you have to rule out other causes as well. So usually when a female is not menstruating, so we start for these stages and see which stage a female has achieved, and from there on, we'll try to figure out if she is having a chromosomal abnormality, a genetic, or it's something else that she's not going having it. So then the premenstrual syndrome. Now we are talking about the PMS. PMS is the management of PMS. PMS is very, very important. At which stage, what you have to give. So starting with the most important thing is there should be physiological, along with that emotional disturbance that occurs within 1 to 2 weeks prior to the menses, and usually lasts for a few days. So same exact question can be asked, like a physiological along with emotional disturbance should be there. So just a physiological disturbance can be given and ask you to label it as premenstrual syndrome. So it's wrong. There should be emotional, like depression, low mood, or whatever is there. And it should be that occur within 1 to 2 prior to the menses and last for the days. Then you can skip the etiology. Mainly, you just need to remember which hormones are there: serotonin, dopamine, and then GABA, neurotransmitters. So then they say at least one effective and one somatic. So that's what I was talking about. They can say only the physiological or can give you only emotional one, but they did not give the physiological. In that case, not PMS. Okay, so it's very, 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 very important. And sometimes we do, okay, oh yeah, this is given, so this is PMS syndrome. So you have to see there should be one of that one, and there should be one of the physiological and both somatic. At least one effective and one somatic symptoms. Like which one is effective? All the mood problems like angry, depression, anxiety, what is this? Confusion, social withdrawal, all of this one. Then somatic is basically breast tenderness, diarrhea, vomiting, anything could be there. So they can give you a scenario where they're talking about depression, or not depression. They will say low mood along with diarrhea, and that usually start before the menses and last during the menses for 5 days. So, and it's going on for 2 cycles at least. Now this is premenstrual syndrome. So if it's happening only one time, this is not PMS. Symptoms occur reproductively during 2 cycles, so it should be there for 2 cycles. I'm putting so much uh, like focus on this one because these are the words. If you don't find this one is not PMS. Okay, so relieved within 4 day onset of the menses and do not occur until at least for the 13th day. Then how you assess it? So this is basically a calendar to checking for that one. How do you start with? So a question can be asked like, she's already now been diagnosed with PMS, and she was already taking SSRIs for depression for some other reason. So in that case, what will you do? So as you can see, the first line is SSRI along with CHC, then exercise, CBT, vitamin B, and then all of this one. At the same time, you have to see if it's already the first line being given, and in that female, can we consider the contraceptives? If not, then we can go for the second phase. But let's suppose if the female has already been given exercise, cognitive behavior therapy, vitamin B12, SSRIs, then the option is basically uh, the combined hormonal contraceptives. So in that cases, we go for combined hormonal contraceptives. Okay. But in the other cases, like she had tried combined hormonal contraceptive before jumping to second, just check for SSRIs. Okay. So you have to see what they have tried and don't assume. Keep on telling you, don't assume. Even they says, oh, she was having PCOS or whatever, and she was using some medicine before. So they did not mention that she was using CHC, like combined hormonal contraceptive. So even this says, oh, she was having fibroid or whatever, she was using any medicine before. Don't assume that she would be using a combined hormonal contraceptive for fibroids or for any other purpose. So in that case, you have to see what she can take right now and don't assume what she has taken before. Okay, if she had tried combined hormonal contraceptive, they will directly or straightforwardly like write it down for you. Okay, so don't just assume for anything I said, like whichever question come from anywhere, don't assume that, oh, she must have done this one or this one must has been done. Okay, then talking about the second line is basically estradiol patches and then levonorgestrel micronized progesterone, and then the high dose of the SSRIs. In third one, GnRH analog and HRTs, and then the fourth one is we usually hardly go to fourth ones. So first, second, and third line is important. It can be asked like this has been tried. Now what will you do next? And they will ask you this is contraindicated and what you can do further. Like she is interested in estradiol patches, so in that cases we go for estradiol patches. Okay. Then premenstrual dysphoric syndrome, it's mainly the diagnosis. That's it. In that cases, there should be 5 of the following symptoms about the menstrual cycle, the at least 1 year, last for a year within like at least one of the following of the first one. So there should be one depression, mood, low anxiety, and all of this one anger, and along with that there should be some of the appetite, insomnia. So PMS usually work out the same, but in that case there should be within 2 cycles. So in this one it should be what 1 year. That's how you go to disorder. Then symptoms occur significantly distress or interfere with the social or occupational. Symptoms may present during the week prior to the menses and may be superimposed on the other psychiatric disorders, provided it is not merely an exacerbation of another disorders. Now we are talking about this one here, the imaging. So for this one, if you could remember the indications, it will be very easy. Otherwise, we are going to do it in the chapters anyway. So you can see the indication that will help you over. You have to choose which answer. Okay. And then one of the question from hysterectomy is like a patient who has had fibroids and she had gone through subtotal hysterectomy and now she's bleeding or she's having vaginal discharge and all of that one. So what is going on, or like which structure is present, and from there you can think of that one. So if you can see, if she's having a subtotal hysterectomy and she's 70 years old, right? So she's 70 years old and now she's having vaginal discharge, some sort of bleeding. So in subtotal hysterectomy, the uterus has already been removed, but cervix is there. So in that case, it could be a cervical cancer, right? So the things like this can be mentioned there to help you to signify what's going on. But at the same time, it cannot be mentioned there to like they are looking for, like if you are understanding that in subtotal hysterectomy which organ is being removed and which is preserved. Like there are certain type of questions that is asked, like in radical hysterectomy, the uterus, cervix, parametrium, uterine artery, everything is gone, but she's still having the vaginal discharge, so it means the vagina is having itself is having problem. Okay, so don't think of anything else. Maybe she's having this one in the cervix cancer. So if she's having vaginal discharge and she's presenting to you after radical hysterectomy, so now they're looking for what will you do in this case. So you have to look for the vaginal, like bacterial vaginosis or yeast infection or those kind of symptoms. But if it's basically a subtotal hysterectomy, in that case, it could be related to cervix. So now you can see how with the name of the just the surgeries, the diagnosis is different. So just by giving you like a surgery name, now they're giving you vaginal discharge. Now I can ask you what is the diagnosis or what is the underlying pathology. Then comes to the disorders of the menstruation, the amenorrhea. One of the most highlighted thing in, especially they do like to ask in the age 13, 15. So you can see if this case of a reassurance or in this case you have to do some tests, further investigation. So you can see primary amenorrhea is no menses by the age of 13 in the absence of the secondary sexual characters. So if you don't know the thelarchy, the pubarchy and all of those ones, you will not be able to understand what are the second sexual characters. So, or no menses by the age of 12 with secondary sexual characters, or no menses by the 2 year after thelarchy. So, if you don't know what is thelarchy and at which stage it shows up, so you'll not be able to make the diagnosis of primary amenorrhea. And it's very important to make the diagnosis of primary amenorrhea and which stage you have to start the investigations for amenorrhea. Then the secondary amenorrhea is basically no menses for more than 6 months, or the 3 months for the documented one. And in secondary amenorrhea, don't forget beta HCG or pregnancy before going for anything else. Then the most common causes of the primary amenorrhea is gonadal dysgenesis, very common, and then Mullerian agenesis, and then along with that functional hypothalamic amenorrhea. And don't forget about the anorexia nervosa and all of that. That is also very common in this one. So now we are looking in this one differential diagnosis where there is the normal breast and pelvis development. So breast is normal. Now the stage of thelarchy and secondary sexual characters is already been achieved. Why, like with secondary sexual characters, why there is primary amenorrhea going on? So in that cases, it could be hypothyroidism, which is very, 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 very common, especially in females these days. Like out of 10 cases I see every day, 8 to 9 cases where they are having hypothyroidism. Then hyperprolactinoma. So don't forget about hyperprolactinoma. In that cases, they will present with headaches or blurry visions or nipple discharge. Then PCOS is also very common where they're having irregular periods or hirsutisms, acne and all of that. Then hypothalamic dysfunction, we already know about this one. Then the normal breast and abnormal uterine development. In that one is the androgen insensitivity, the congenital adrenal hyperplasia, and then the anatomical abnormalities, how you figure out this is Mullerian agenesis, uterovaginal. That one we have to do the ultrasound to figure it out. So don't go for transvaginal ultrasound. Transabdominal ultrasound is preferred over the primary amenorrhea because the patient is not sexually active. Uterovaginal septum and imperforated hymen. Then coming to the without secondary sexual characters. So in that cases, there is high FSH. The gonadal agenesis like Turner syndrome, normal sex hormones, 46SS. And then comes to the hypogonadotropin hypogonadism. So this one is hyper and this one is hypo. So in that cases, the FSH is high. In this case, FSH is low. So for your information, in constitutional delay is the girl. So we usually don't go for that one. Then the Kalman syndrome, head injury is one of the most common, and it can be asked in the scenario that after head injury, now she's having primary amenorrhea. What could be the cause? So the problem is coming from the pituitary gland. Pituitary adenoma, then endocrine disorder, which one? Type 1, because it is linked with the other ones as well. Then IBD, like any kind of autoimmune diseases that usually comes with a hypogonadotropic hypogonadism. So just for your easiness. So how do you remember that which one comes with which one? So how do I kept it in mind that hypogonadotropin hypogonadism is linked with the autoimmune, all of the conditions. Then functional hypothalamic and Asherman syndromes like uterine defect. Then we know hyperandrogenism, in which conditions and in which one there is without hyperandrogenism. So just functional hypothalamic amenorrhea is the most common cause of the secondary amenorrhea. Then comes the amenorrhea in history and the physical examination. So don't forget about pregnancy. Then second one is basically functional hypothalamic amenorrhea. This table is very, very important. It helps you to solve a lot of MCQs. Like mainly that MCQs are coming from the gynecology will be covered from here if you try to memorize it or make sense with it. So we start with history and physical examination. The first was this primary amenorrhea, and then there is secondary amenorrhea. The primary amenorrhea is we are going to check, like this is basically first time happening. So in that case, we check for the breast development, the pubic hairs, the axilla hairs, all of those ones. And then from there on, if there is yes, it is there, then in that case, we go for karyotyping. Then in that case, we go for karyotyping XX and XY. So if this is basically X, like the X is there and then there is one X missing, that is basically androgen insensitivity syndrome. But in the XX, there could be the inside pathologies problem. Like inside could be cervical, Mullerian, imperforated hymen. So a question or MCQs can be asked where this says that secondary sexual characters is being achieved, but there is no periods and mother is concerned. So in that cases, what will you do, or what is your differential diagnosis? So in that cases, think for something imperforated hymen. Don't go for something invasive androgen and insensitivity syndrome. Then they're talking about the secondary sexual characters is not achieved. So usually, if there is not achieved, we check for the hormones. That's our main aim. So in that case, if we go for FSH and LH. If FSH and LH is high, so this is hyper. Then if it is no, then this is basically hypo. So for your understanding, you need to see a primary amenorrhea, then secondary sexual characters. If yes, then go for karyotyping. Or you don't go for karyotyping. That's something very uh, genetic thing. So we go for imperforated hymen, cervical agenesis. That's what we directly jump into. But now we are talking about the secondary sexual characters are not there. Then what's your investigation of choice, or how you will approach that case? Go for FSH and LH. Okay. So on the basis of sexual secondary characters. So which ones? The breast and then pubic hairs and all of those ones. Then comes the secondary amenorrhea. Don't forget about beta HCG. Beta HCG is something you have to start with, and then we move on to other. If beta HCG is positive, then definitely it's a pregnancy. And don't forget about pseudo pregnancy. Pseudo pregnancy is also very common in the psychiatric patients. So they start thinking like it's in a conversion syndromes or disorder. They start thinking that they do have it and all that. Then comes the negative one. In the negative, there is basically you check first of all prolactin. That's very easy approach of how that's how we do it. So we go for, like, if a patient is having secondary amenorrhea, we do go for the PT test, urine PT test, and when it came out negative, and we ask, like, usually the pregnancy, or sorry, the periods should be missing for 3 cycles. So if 3 cycles is missing, then for the next one we go for PT. Like, obviously PT is done after 1 cycle, but yeah, after 3 cycles we go for prolactin level, and prolactin level is high, then we check for prolactinoma, and then we go for MRI. It's very less likely we go for CT scan, but in the books it's written CT scan. But in the other one, we go for MRI and then go for thyroid as well. Okay, because if it's linked to the pituitary, then could be thyroid could be the problem as well. Then if the prolactin is normal, then we go for progesterone challenge, giving the medicine like progesterone. If there is a withdrawal bleed, then we check for the LH, FSH. So in those ones, if it's high, then basically the PCOS. If it's normal, then we go for MRI of hypothalamic checking for the pituitary. But if there is no withdrawal bleed, it means the uterine is the defect, because the progesterone is not working on the uterus and there is nothing happening. So the problem is from the uterus. So progesterone, this question is something very, very, they do give the progesterone challenge and ask you, there is no withdrawal bleed or there is a withdrawal bleed. How do you assess the case? Or what is your differential diagnosis, or what is your diagnosis? Okay. So with progesterone challenge, and sometimes they give you a secondary amenorrhea case, and they do mention in the scenario that pregnancy is being ruled out. What is the next step? So it's very less likely we go for prolactin. They just directly jump to progesterone. So in that case, why are we not going for prolactin? Because if there is no headache, no blurry vision, no breast nipple discharge, so in that cases we don't go for prolactin. So don't always follow what the written is in this table. So if there is no beta HCG, the answer could be progestin challenge, because progestin challenge is something that you can do right away, and prolactin is something that takes a lot of time. And it's very, like, if there is no symptoms, why going for prolactin? So in that case, if giving progestin is more easy and more convenient, and the results are mainly coming from the progestin. So just for your knowledge, we go for Depo-Provera or whatever for the progestin, and then that helps to figure out if there is a problem with the uterus and all not. And even for the cases like PCOS, they do give you questions where there is hirsutism and all of that. So you can directly jump to LH and FSH. So please look into the scenario. What kind of findings is there? What kind of symptoms is there? On the basis of those symptoms, please understand what they are trying to ask. If they are giving you a PCOS case, they don't want you to do a prolactin test. Why would they want you to do a prolactin test? Is there any link with prolactin with PCOS? No. So in that case, they're looking for LH and FSH. If they're giving you a case of with no bleeding, in that case, they're looking for progestin, not for or beta HCG, not for prolactin. Okay. So don't just, assume that they're asking for prolactin. That's what I keep on telling you. If they're talking about secondary sexual characters, in that cases, you have to talk about FSH and LH instead of talking about karyotyping and all of that. So please see when the scenario, they will give you a little bit of very small hints because the scenario sometimes 7 to 6 lines. So it's very hard to, take out the important points. So, in your case, what you can do is highlight your points that you feel like it's important. And when you are going through it again, like one time you will not be able to understand the MCQs is, what MCQs is. And in the second time, when you highlight it the first time, you can read the second time, you will be start making sense. And for me, I read the MCQs at least 3 times, and after third time, I go for the answer. Until unless if it's something straightforward, then the first attempt is okay. So if you are very smart and you think that you are able to understand things, then you can go for at least the second time, because for the first time you understand something else, and when you read it again, they are asking for something else. Okay, so for the first time, do highlight your things, and then is the second time when you are reading it, you will start getting what they are asking for. And let's suppose if you read the statement and you are not able to understand what they are asking, then read the answers and try to link the answers with the question things. Okay, that is also one of the very good strategy that helps you to understand what is linked with which one. Okay. Then we are going to start with beta HCG hormonal workup like TSH, prolactin, FSH, LH. How do you go for that one? Then the progesterone challenge checking for withdrawal and withdrawal bleed. In that one, we go for Depo-Provera. Any uterine bleed within 2 to 7 days after completion of the Provera, it's basically considered as a positive withdrawal bleed. So withdrawal bleed suggests of adequate estrogen levels to thicken the endometrium. So if no bleeding, then there might be a secondary like estrogen problems and coming from the pituitary or somewhere else. So in that cases, you have to introduce those hormones. Then the karyotyping checking for the primary ovarian insufficiency and ultrasound to confirm for the PCOS. Now, when we are talking about the androgen insensitivity syndrome, in that one, you have to go for the gonadal dissection of the puberty, psychological counseling. So please, whenever we are talking about the primary amenorrhea and they're asking how you will deal with this case or how you will approach this case or what is your next step. So obviously we go for gonadal resection, dilation or whatever. The first thing is psychological counseling. Okay. So let them know what's going on and then preparing them, letting them know what's your next step and all of that. So psychological counseling comes first and then go for the gonadal resection. Even for the imperforated hymen, vaginal septum, cervical agenesis, Mullerian agenesis, some in those cases we do go for whatever the gonadal resection surgery and all that. But the first thing they are looking for that are you a good doctor? Like did you do the psychological counseling or not? Okay, so you have to start with that one. Then we are talking about the secondary amenorrhea. In the secondary amenorrhea, you have to look for the HPO, like hypothalamic axis dysfunction. What are those ones combined with OCPs and giving those one? So in that cases, always think of osteoporosis as well. Then hyperprolactinoma, we already discussed how you are going to approach that one, and you have to give the bromocriptine. PCOS, we'll discuss the PCOS premature ovarian failure. That one is basically linked with the diabetes, hypothyroidism, hypoparathyroidism, hypocorticolism. So it's important, this primary ovarian failure. It can be asked you to make a diagnosis of this one. Uterine defect is evaluation with the hydrosalping, so checking for the tubes if they're patent or not. The Asherman syndrome, then hysteroscopy. Secondary amenorrhea is pregnancy until proven otherwise. Then we are talking about the abnormal uterine bleeding. This is also an emergency case. It can present with a lot of bleeding. In that case is how you're going to approach it. So usually for heavy bleeding, it's basically could be from endometrium, from anywhere else. And then from intermenstrual bleeding, like during the menses, it could be polyps. And then the which is basically unpredictable, that they come from the malignancy or come from ovaries. So how you are going to approach, obviously, all the single questions like is it regular, irregular, how heavy, how much pads do you use, and how is it affecting your quality of life? Don't forget about the quality of life, because from there on we decide how bad it is. If it's affecting their daily life, she's anemic, in that cases you have to do something, because like if let's suppose that this is a fibroid case, if fibroid is not affecting anyone, in that cases we don't do anything. But if the fibroid is affecting their quality of life, then we go for the treatment. Okay, so any of the gynecology case, if it's not affecting their quality of life, usually we don't do anything for that. But if there is affecting their quality of life, even like little bit of discomfort or whatever is bothering them, in that cases we go for the treatment. So postmenopausal bleeding is endometrial cancer, not cervical cancer. It's a very common question, and until proven otherwise. Then the abnormal uterine bleeding, change in frequency, duration, and amount of flow. Then we are talking about the polyps. And the polyps, we do transvaginal sonography. Usually we go for transvaginal sonography for every kind of abnormal uterine bleeding. Otherwise, like if it's you did not find anything that, then we can go for different cases like checking for whatever it is. In polyps, we do polypectomy or remove the polyp, then adenomyosis, transvaginal sonography, leiomyoma, transvaginal sonography, and then malignancy transvaginal, because transvaginal is something that is shows something right away. So in that case, we go for that one. Then comes the non-structural one, the coagulopathy, ovulatory dysfunction, endometrial, and then iatrogenic in that one. Just except for the endometrial, because we have to check if it's a cancerous or not, then we go for the, or how much is the thickness. We go for endometrial biopsy. Otherwise, we go approach from CBC and all of that, checking for whatever is going on. Then one of the best approach for the abnormal uterine bleeding, usually we do start with like combined hormonal contraceptives and all, but the first step is basically starting with the tranexamic acid. But if they are asking for the best treatment or asking for what is the goal of treatment, then in those cases you have to go for the combined hormonal contraceptives or OCPs or whatever it is. But if they're asking for first line or moving forward, then in those cases, if she's having a lot of bleeding, then go for tranexamic acid. Then the treatment is resuscitate underlying lesions, then mild abnormal uterine bleeding, we go for NSAIDs, anti-fibrotic, combined hormonal contraceptive, progesterone, Mirena, IUD, and correct the anemia, starting with iron. So here is one thing. I mean, we do read it many times, then we do keep missing this one. So if this is an acute severe abnormal uterine bleed, replace the fluids, consider admission of estrogen. Uh, like I don't know how it works, but usually the book says for severe abnormal uterine bleeding, estrogen is one of the very helpful thing to stop the bleeding. But in our practice, we go for progesterone. I don't know why, and I just never got to get this answer from even Chat GPT or whatever. If anyone has an idea, do let me know. But in the book says where abnormal uterine bleeding, the answer is that you can go for estrogen. Estrogen do helps with the severe abnormal uterine bleeding. So in your question, if they ask for severe and abnormal uterine bleeding, what do you go for? So the answer is estrogen. Okay, with the gravel or antifibrinolytic, that one, then tapering OCP's regime 35 and then going with the gravel, so it can cause the vomiting as well. So then the maintain with the monophasic OCPs, then medical could be the progesterone, high dose of progesterone can also be considered, denazole, GnRH agonist, and allopurinol. So we can see that here says high dose of progesterone can also be considered. But here they directly says that estrogen can be used. But I don't know. The answer is if they says that they're talking about severe abnormal uterine bleed, in that case, the answer is estrogen. But if they says that she is having contraindication with estrogen, or she does not want to go for estrogen because estrogen itself has a lot of side effects, then in those cases we go for high dose of progesterone. Polypectomy, myomectomy, and then uterine artery immobilization, then endometrial ablation, and then hysterectomy can be done. Then comes the dysmenorrhea, where there's a lot of pain. Then primary dysmenorrhea is basically cramps during in the absence of the demonstrable disease. There is any disease present like endometriosis, adenomyosis, and fibroids. Primary dysmenorrhea and the secondary dysmenorrhea. Primary dysmenorrhea is basically when there is no disease underlying, it's just the pain and vomiting, nausea, bowel movements is disturbed. So don't miss this, mix the primary dysmenorrhea with PMS. It's something like you need to know. This is basically along with a lot of cramps, pain, and then occur. So in this one, it's not having any mood problems, depression. In that one, they will surely mention that she's having low mood or crying often or something like that. In this one, they can present with a lot of pain, she's crying, but they won't say that it's going on for too long. Maybe only when she's having pain, then she cries, but otherwise she's fine. Assess to the associated of dyspareunia, abnormal bleeding, infertility, and then pelvic pathology you have to look for. That's why you have to do ultrasound and then checking for the exercise, local heat, NSAIDs, and combined hormonal contraceptives. Then we are talking about the secondary one. In the secondary one, similar lesions like that one, but there should be like underlying pathology like endometriosis, adenomyosis, and uterine fibroid. Then there is dyspareunia, abnormal bleeding, infertility. Bimanual examination is one of the most common. We check for the uterine tenderness, fixed. So if they ask for secondary dysmenorrhea, or they give you an idea of that, you are thinking of fibroids or whatever, in that case, they're asking for what is your first line or what is your next step. So don't forget about bimanual examination, then go for ultrasound. Okay. I always said when they ask about first line, in that case, is go for non-invasive. When they ask for later on diagnostic procedure or whatever, in those cases, go for ultrasound, laparoscopic, those ones. Then in the bimanual examination, what are you going to check? That the uterus is fixed or not fixed, it is tender, it is nodular, or is there any irregular uterus or irregularly enlarged uterus, or how is it? Okay. Then the vaginal and cervical cultures, like it could be any infection going on. When we are talking about endometriosis is like, what are the differential diagnosis? Could be any infection, usually the PID or salpingitis, ectopic pregnancy, all of those ones. Then the endometriosis comes with D's: dysmenorrhea, dyspareunia, dyschexia, dysuria. So it can be given in a scenario where there is a problem with dyspareunia. Okay. Now she is presenting to you. In that cases, what are you going to think of? So your diagnosis shouldn't be based upon only dyspareunia. You have to see how old is she. Usually, because this says it's present between 25 to 30 years. If it's more than 30 years, it's basically we link towards the adenomyosis. But if it's 25 to 30, then you have to think of endometriosis. Then the family history is very, very important. They will say that, one of the family member had this problem or something like that. Then obstructive anomalies of the genital. Then the age should be more than 35. Early menarche should, like in that case, there is an early menarche. So if any of these risk factors are there, and then along with dyspareunia, then definitely 100% you can go for endometriosis. But if not, these things are not there, and then just dyspareunia is there, don't just 100% go for endometriosis. I have seen many cases where there is dyspareunia, but it's not linked with this one. This should be a good differential diagnosis, but it's not your 100% diagnosis. So don't forget about other causes as well. Maybe a PID is there, maybe something else is going on with there, like okay. So family history, then abnormalities, nulliparity is one of the most important thing that can be mentioned. Early age more than 25, and then early menarche. It's basically less than 11 to 13 years. Ovaries 60, and then patients have the ovaries involvement, and then broad ligament could be there. And then all of this one, they could be there. So mainly it's in the 60% in the ovaries. Maybe in symptomatic, and men present with one of the three presentation. What is that one? It's either with the pain, either with infertility, or either with the mass. So usually a lot of cases do present with infertility, but don't forget about pain as well. Pain is something that can be like, dysuria, hematuria, and all of those ones, sacral back pain, dysmenorrhea. So pain could be one of the most leading factor that can lead toward going for the ruling out what's going on. Then infertility is 30 to 40% of the patient with endometriosis will be infertile. So infertile is basically linked with endometriosis. Then there is a mass present, like ovarian mass could be there in the physical examination. That's why you have to do the bimanual examination to check for the nodularity or the retroversion or tenderness or any adnexal mass. So don't forget to do the bimanual examination. Now we are going for the very definitive diagnosis. Then the definitive diagnosis can be based on the direct visualization, how you go for that one. This is basically laparoscopy. So don't go for transvaginal ultrasound, although we go for transvaginal ultrasound. But in endometriosis, the differential or the gold standard one is laparoscopy. I know it's something very unusual, although in our practice we go for transvaginal ultrasound right away. But the gold standard is laparoscopy. If they're asking in the exam, then the answer is laparoscopy. In that case, we'd go for the biopsy and histology exam of the specimen. Then in laparoscopy, what do we check? The mulberry spots, anywhere in the pelvis, the endometrioma, chocolate cyst. So they can give you a picture of chocolate cyst, or they can give you that, oh, on the investigation, we find the chocolate cyst, what could be the differential diagnosis or what could be your diagnosis. Then powder burn, early white lesions, and then peritoneal pockets, and then go for CA-125, which should not be used as a diagnostic one. Endometriosis, in that case, we check for the history. even with a negative exam, pelvic pain that is not primary dysmenorrhea should be considered endometriosis until proven otherwise. So they says if there is a primary dysmenorrhea and there is a pelvic pain that is not primary dysmenorrhea, in that cases we just go for endometriosis until proven otherwise. Then medical management is the mainstay. So if you are suspected, like if you are thinking, so as I told you, when this is dyspareunia, right? But they did not say that this is not an age factor, this is not whatever it is, blah, 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 blah. Like your diagnosis was not going towards endometriosis. They just mentioned that this is dyspareunia, okay? But since in back of your head, you are thinking this is endometriosis. So in that cases, you can start the treatment. And we know the treatment is combined hormonal contraceptives. So whichever the diagnosis would be, it will be covered with CHC. So that's why they said even you suspect endometriosis, the treatment you have to start. Don't go for any laparoscopy or whatever procedure. So if you're thinking that this is dyspareunia and you are thinking, oh, it could be endometriosis, so you can start the treatment. So in that case, is go for CHC progesterone alone. And then failure of the first line, go for either laparoscopy or the second line. Second line is basically GnRH or progestin IUS. Mainly females go for the second line treatment. They hardly get any chance to do the laparoscopy, but we do put the request for laparoscopy. Then the failure of surgical or management treatment, in those cases, going for the invasive, like consider diagnosis, additional testing, and chronic pain management, multidisciplinary approach, checking for what other options a patient can have for the endometriosis. So in your case, let's suppose if they gave you a scenario and you are thinking of endometriosis and they ask what is the next investigation, or sorry, what is the next step? So don't go for laparoscopy. Your answer should be CHC. Okay. As you said, the surgical confirmation of disease is not required prior to starting any medical therapy. So CHC. But for me, I feel like if there is any gynae case, don't directly jump to anything before going for CHC, like wherever it's possible. Then there is talking about, what could be the other symptoms like intestinal obstruction, because if it's at that place, then that one you have to do. Then the NSAIDs for the painkillers, and naproxen works really well. Then the first line is OCPs, progesterone, Mirena IUS. Second line is GnRH analogs. And you need to remember the side effects of that one. So side effects is hot flashes, vaginal dryness, and then decreased libido. For more than 6 months, you have to add the progesterone or the estrogen. So in that cases, you have to go for that one to prevent the decreased BMD. Danazol is basically weight gain, fluid retention, acne, hirsutism, voice changes, those ones. Then surgical treatment is basically conservative laparoscopy using laser, electrocautery, and laparotomy. Definitive is hysterectomy, and then doing the BSO, like bilateral salpingo-oophorectomy. Best time to become the pregnant is right after doing the conservative surgery. So you can tell if a female wants to get pregnant, how you will approach that case. If the patient is not planning to become pregnant, so in that case, you have to go for the ovulation suppression right away. Above treatments are for the pain, not for the infertility. So associated with endometriosis, so usually involves surgery and reproductive technologies. Also, the management for endometriomas is surgical for symptomatic and expanding masses, but this can decrease the ovarian reserve. So if it is asymptomatic and small, then no surgery is needed. I keep telling you that don't go for any surgery if the female wants to preserve or wants to get get pregnant in the future. So in that case, is try to keep it as medical as you can, but wherever possible, we can go for surgery as well. Then comes to the adenomyosis. In that cases, as you can see, the age more than 35. In that cases, this is basically adenomyosis. Mean age at presentation is 40 to 50. Adenomyosis is a common histological finding. So then it's basically often asymptomatic, heavy menstrual bleeding, dyspareunia, dysaxia, uterus is symmetrically bulky, and then Halban sign is there. It's mainly a clinical diagnosis. So regardless of anything, this can be given and ask you what is the next management. So in that cases, don't go for anything. So the answer is clinical diagnosis. Final diagnosis of adenomyosis is based on pathological but predictably identified on MRI. Then medical treatment, iron supplements, analgesics, NSAIDs, Mirena IUS, CHC, GnRH, and danazole, and then going for the hysterectomy. Now, a question can be asked, what could be the most important factor, or what is the most common thing that can be linked with adenomyosis, okay, or with